vancomycin. Pneumocystis pneumonia, or better known as PCP. This is pneumonia caused by the fungus pneumocystitis, pronounced, and there's the pronunciation, Urovetzi. One of the most common opportunistic infections in people with HIV/AIDS. PCP is often the AIDS-defining illness in patients infected with HIV, occurring most frequently when the CD4 plus cell count is less than 200 cells per cubic millimeter. Now, pneumocystis pneumonia, PCP. Now, other groups of people at risk for PCP include people who are receiving immunosuppressive therapies, such as organ transplant patients, people with connective tissue diseases or chronic lung diseases. Common symptoms include a subtile onset of progressive dyspnea, non-productive cough and low-grade fever, tachypnea, tachycardia, normal findings on lung auscultation. Pneumocystis pneumonia requires examination under a microscope in order to identify pneumocystis. Requires a clinically relevant source such as sputum, bronchoalveolar fluid, or lung tissue, because pneumocystis cannot be cultured. Treatment for PCP includes the following: trimethoprim, sulfamethoxazole, which Bactrim, Septra, and Cotrim. This is the first choice. Primaquine plus, clindamycin, atovaquone, and these are alternate choices. Okay, nursing interventions, initial assessment and vital signs. We assess for any immediate interventions needed. We complete full examination including history, chest x-ray. We do blood work, including CBC, CMP, hepatic indicators, inflammatory markers, and blood cultures. Blood cultures should be drawn prior to the administration of IV antibiotics, and I think just about everybody has that in their pneumonia protocols. Clinical features which may suggest specific pathogens. This is things when a patient presents with these signs and symptoms, we might be able to begin to target what kind of pathogen is causing it because of their symptoms. S. pneumoniae has an acute onset, high fevers, and pleuritic chest pain. M. pneumoniae, gradual and subacute onset, slowly progressing to higher fever and persistent cough, headache, and pharyngitis. Staphylococcus aureus pneumoniae. Now, this often follows viral infection. Pneumocystis pneumoniae, or PCP. These patients will have a history of immunosuppression, subtile onset of progressive dyspnea, non-productive cough, low-grade fever, tachypnea, tachycardia, normal findings on lung auscultation. Viral etiology, more common in children with slow onset of rhinitis and wheezes. Now, there's a severity assessment in hospital. When a diagnosis of community-acquired pneumonia is made at presentation to the hospital, we can determine whether patients are at low, intermediate, or high risk of death using the CURB-65 score, and it is based on the point system. For confusion, you give 1 point. The blood urea nitrogen above 19 milligram per deciliter, you give 1 point. If they have a respiratory rate equal to or greater than 30 breaths per minute, is 1 point. Systolic blood pressure of less than 90 or a diastolic blood pressure less than 60 is 1 point. And age equal to or greater than 65 years old is also another point. And you add all these up, and that gives you a CURB-65 score. Now, the CURB 65 score. You consider home-based care for patients with a CURB 65 score of 0 or 1. Consider hospital-based care for patients with a CURB 65 score of 2 or more. And you consider intensive care admission and assessment for patients with a CURB 65 score of 3 or more. Now, safe discharge from the hospital. When we discharge them, we have to be sure that it's safe. So here's some guidelines. Do not routinely discharge patients with community-acquired pneumonia if, in the past 24 hours, they have had 2 or more of the following findings. Temperature higher than 99.5, respiratory rate equal to or greater than 24 breaths per minute, heart rate over 100 beats per minute, systolic blood pressure of equal to or less than 90, oxygen saturation less than 90% on room air, an abnormal mental status, or not able to eat without assistance. Now, these have been some advances in the treatment of CAP, or better known as community-acquired pneumonia. Severe pneumonia occurs in up to 18% of hospitalized patients with community-acquired pneumonia and still carries a high morbidity and mortality rate. Systematic adjunctive corticosteroid therapy attenuates the local and systemic inflammatory response and may potentially decrease the development of acute respiratory distress syndrome, or ARDS, sepsis, and mortality. Now, criteria for treatment with corticosteroids. Indications. This is patients with serum levels of C-reactive protein of over 15 milligrams per deciliter. Contraindications would be influenza A, H1N1 pneumonia during influenza season, general contraindications for corticosteroid administration, such of course as diabetics needing treatment with insulin, and major gastrointestinal bleeding within 3 months. Now, we have a corticosteroid algorithm. Okay, first we select patients with criteria for severe CAP, IDSA, ATS guidelines. Okay, we discard influenza A, H1N1 pneumonia during influenza season. Discard general contraindications for corticosteroid administration. Diabetes mellitus needing insulin treatments ruled out, and major gastrointestinal bleeding within 3 months is ruled out. We select patients with serum levels of C reactive protein of over 15 milligram per deciliter. Select the most appropriate empiric antibiotic therapy, and we start corticosteroids as soon as possible. We give 0.5 milligram per kilogram every 12 hours, methylprednisone or equivalent for 5 days. And they recommend 5 days of treatment, although the meta-analysis of Nile et al. Recommends more than 5 days. Okay, we're moving on to COPD. Chronic obstructive pulmonary disease was the 4th leading cause of death worldwide in 2012. Now, in 2015, the World Health Organization updated its global initiative for chronic obstructive lung disease. It's also known as GOLD. So if you hear the term GOLD, that's what it means. Guidelines. Classifying patients with COPD based on disease burden as determined by symptoms, airflow obstruction, and exacerbation history. Pathophysiology. COPD is a chronic lung disease characterized by progressive airflow limitation, usually measured by spirometry and chronic airway inflammation. Now, emphysema and chronic bronchitis are often used synonymously with COPD, but there are important differences. Patients with chronic bronchitis do not necessarily have the airflow limitations found in those